Good morning, doctors. Today, we're going to delve into a critical topic within endocrinology, specifically Graves' disease. This autoimmune condition is a leading cause of hyperthyroidism, characterized by an overactive thyroid gland. First, let's explore the genetic predisposition. Certain genes, namely HLA-DRB1, HLA-DQB1, and PTNP22, have been associated with an increased risk of developing this condition. Graves' disease is also often seen in conjunction with other conditions, including polyglandular autoimmune syndrome, pernicious anemia, vitiligo, and diabetes. Graves' disease is the most common cause of hyperthyroidism in the United States, with a particular predilection for women between the ages of 20 and 40. Its etiology involves an interesting interplay of genetics and environmental stressors, such as childbirth, infection, steroid withdrawal, and trauma to the thyroid. These factors trigger the production of autoantibodies against the thyroid-stimulating hormone receptor, leading to an overproduction of thyroid hormones. The elevated thyroid hormone levels, in turn, suppress pituitary TSH via a negative feedback mechanism. The clinical presentation is diverse, with symptoms including tachycardia, palpitations, fatigue, muscle weakness, weight loss, increased activity, tremulousness, diarrhea, warm moist skin, sweating, and heat intolerance. Patients might also experience eye pain and double vision due to ophthalmopathy, a key hallmark of Graves' disease, although not always present. On physical examination, you may note hypertension, arrhythmias, symmetrical thyroid enlargement, and myxedema. In terms of diagnostic workup, initial testing includes a TSH level. If TSH is low, the next step is to assess thyroid hormone levels. Autoantibody assays are also essential, with anti-TSH antibodies being almost always positive. Imaging studies, like a radioactive iodine thyroid scan or orbital CT scan, MRI, can also help confirm the diagnosis and differentiate Graves' from other causes of hyperthyroidism. Differential diagnoses include multinodular toxic goiter, toxic thyroid adenoma, and iatrogenic causes, such as excessive levothyroxine intake. Treatment is often tailored to the individual patient, but it generally begins with beta blockers like propranolol for symptom management. Antithyroid drugs like methimazole and propylthiouracil serve as second-line options, inhibiting thyroid hormone synthesis. When medical management isn't successful or suitable, we might consider more definitive treatments like radioiodine ablation or even surgical thyroidectomy. However, treatment approaches differ in certain situations, such as pregnancy or when the patient has ophthalmopathy. Finally, we must remain cognizant of potential complications such as thyroid storm, a life-threatening condition that can lead to fatal arrhythmias. In pregnant patients, anti-TSH receptor antibodies can cross the placenta and lead to fetal hyperthyroidism. Also, remember that thyroidectomy carries risks including hypothyroidism, laryngeal nerve palsy, hypoparathyroidism, and hypocalcemia. In summary, Graves' disease is a crucial topic in endocrinology, with a diverse clinical presentation and a significant impact on our patients' lives. Understanding its pathogenesis, recognizing the symptoms, and being familiar with the best course of treatment can markedly influence patient outcomes. Now, I encourage you all to take this knowledge and apply it to clinical scenarios. Practicing multiple-choice questions, MCQs, on this topic will not only cement your understanding but also prepare you for real-world patient cases and examinations. Remember, the more you practice, the more comfortable you'll become with this material. Thank you for your active participation today, and I'm excited to see how you all progress in your understanding of Graves' disease and endocrinology as a whole.